at is we really want to, not just for these data points, but we're doing these in other areas as well. We want to find the best way to collect this information in a way that creates the least disruption to the existing reporting that you all have, and really prevents the need for some additional deliverable. What we're really hoping is that we can integrate all of the data we need into reports that you already submit, and wanting to find the best homes for those. So that's what we're here to talk about today.
Thank you so much, Amanda. Before we move on, now we're going to kind of pivot a little bit and dive into the actual changes that you received in the documents that were circulated before the meeting. Before we do that, though, let's maybe pause and see if there are questions from anyone before we launch into the changes about the background, or anything that you want to kind of dig into before we start talking about changes. I'm not seeing anything in the chat, and I'm not seeing any hands. Welcome folks to kind of chime in as we move through things here. This is really intended to be an opportunity for us to discuss together. And we really want to hear feedback from all of you. Okay, I'm going to move us then to the overview of the NOABD log changes. So we've added a few columns here, and Summer, do you maybe want to cover these two items really quickly, and then I'll bring up the kind of the log so that we can take a look at it together?
You bet.
Let's see here.
She's gonna pull. Here we go.
All
we'll
right.
look at the NOABD log first. Okay. So in this particular log, we want to add in two columns, one for diagnosis code, one for procedure code. This is similar to what we already have on the PA log. So we are already capturing diagnosis and procedure codes on the PA side, but we now need them on the claims denial side as well, because those aren't being captured on the PA log. And for the PA info, we can go ahead and cross-reference that using the PA ID to populate this log as needed. And we can do that on this side. So we don't need the PAs on this log. We just still need them on the PA log. And then we want to capture the claim ID, diagnosis, and procedure code here.
All right.
Okay.
I'm going to go over to these over here. And I see a hand. Christina, do you want to go ahead before we go on to the next one?
Sure. I took this back to our claims team, so I do have questions relevant to the tabs and columns when it comes about. But the claims team is wanting to know if it's all of the DX codes that are listed, or is it just going to be like the primary codes that need to be listed? So I know for like the PA tab, if there's multiple, then we list the multiple, but for claims, it can get extremely extensive on some cases. So they're trying to get clarification on, is it just going to be the primary, or is it going to be everything that's submitted?
I think it would be the latter, and I think we're open to, so we were thinking the latter. This would align with kind of what you're expected to include in the NOABDs, the actual notices that are sent to members, where we have asked, for diagnosis and procedure codes to be included. So that's the idea, is to have that included here, right, as well. But I'm open to kind of any feedback, and I think I'm hearing more of an issue on the claim, on the post-service side, right, than on the pre-service side. But are there any so for the NOABDs themselves, for the claims, I know all of you are kind of taking different approaches. Some of you issue, a notice that might have multiple claims included in that notice, related multiple claims that are included in the notice. And some of you issue kind of individual notices for each of those claims. So I think that there's maybe, we'd be open to any feedback or suggestions on how to approach this. I think the challenge is just that obviously everybody's addressing this in a different way, right, within the actual notices. And for our purposes, we really want to be able, so I talked a little bit about the reporting to CMS. One of the issues that came up in that report is kind of a confirmation or verification validation of the services that are actually being provided, and kind of really having all of the diagnosis and procedure codes available to us would allow us to kind of slice the data in different ways to be able to show that we have, we've, for example, when looking at the prescription drug service type, we'd be able to see, what prescription drugs were associated with which diagnoses and procedure codes. So anyways, I will stop talking and see if there's any kind of additional feedback that we might consider here in terms of how to approach it for claim denials. All right, let's see. I thought I saw one more hand up, but I don't see another hand up anymore. Did anyone else want to comment verbally? Anna.
This is Anna. I just put a question from our claims team in the chat. Would this diagnosis code, would it include all diagnosis codes on the claim or just those that are mapped to procedure codes? Sometimes there will be many, many diagnosis codes, but only some of them are mapped to procedure codes. Again, is it just the ones that are denied? Because on our NOABD letters, often we have, a list of like, these things were approved and these things were denied or modified, to make it clear to the member what is going on. And for some of the claims, it becomes very complex when there's a lot of things happening on inpatient claims and things like that. So that was a question. All diagnosis codes are just ones that are mapped. And then also on the other side, for the procedure codes, what about inpatient claims that don't have procedure codes and maybe have a revenue code or something like that, where there isn't a CPT or HCPCS code?
Really great questions. I think we'll take some of those back and think through them. The revenue code piece, I think I don't know that we've thought about that yet. I know that comes up in very specific instances, so we'll probably need to take that back and think through that. I am gonna kind of hedge and say that we probably are going to follow maybe a similar approach as to the notices, where we would want to likely see those diagnosis codes that are mapped to actual procedure codes for those services that are being denied. I'm not sure that we would want the universe, but like I said, let us take that back and maybe talk through it and see where we land on that.
Thank you.
And then it looks like Rihanna had a question. I'm not sure if it was technical in nature, but I would just say yes. If there are multiple codes, they would be captured the same way here on the NOABD log as they currently are being captured on the PA log. That means like with a semicolon in between them, or if you have a partial denial, we want to see multiple lines on the tab to indicate which lines were denied, which lines were approved. And in this case, on the NOABD side, we're only interested in the denial portion of that. I'm not sure if that answered your question all the way. If not, please let us know.
And I would also, we do have our data analyst that is the lead on this specific deliverable. So Shivani, I welcome you to kind of chime in anywhere here that you would like to add to that. I will maybe as a side note say that we are working through updates to the instructions. Once we land all of this here, we will kind of turn to maybe a conversation about the instructions and updates to the instructions to correspond with the changes here. And happy to kind of circulate those to the work group as we work through that and finalize that piece. And then I see one more question in the chat about NEMT. So I don't, let's see. I don't know, Summer or Shivani, maybe if you can help me. I don't think a blank would work because we definitely want to be able to track NEMT, but there probably is a different, there's probably,
Actually,
go ahead.
we have been accepting blanks
Okay.
in certain situations where it truly is, there's no data, related. We don't want to see NA or N/A or any of those other types of conventions. We would just prefer it blank. That could change, but that's how it's been done historically.
Okay, thank you for that. Okay. And so Pamela, that'll be maybe something that we take back and consider as we're updating the instructions to figure out if we keep it as such or if there's something else that needs to, a different approach maybe to specifically for NEMT. Okay, any questions about the issuing contractor type or the issuing contractor name? Or comments, feedback on that?
This is Christina. To clarify, it's going to be whether it's C, N, or S. Like that's what we'll have to put in the log. Okay, perfect. Thanks.
And this isn't kind of an initial draft. So, we need to, as I mentioned, we need to update the instructions and we'll figure out if that changes or not, but it'll might look something similar to that. I don't know if Shivani or Summer, you want to add anything to that?
Well, I was just sorry to clarify, wanted to make sure that you weren't looking for like the actual, whether it's going to be like for us, it would be EOCCO or it would be whatever the other subcontractor is.
The
No,
actual
okay,
names,
perfect.
no.
Okay.
I don't think that was what we envisioned, but I see Summer's thinking, so I'm gonna see if she has something to say.
Yeah, we're kind of looking for two descriptions here. One is the type, was it a CCO or subcontractor or another subcontractor or downstream entity that's non-NEMT. So that would be indicated with the code C, N, or S. And then in column P, we would want to see the name. But I think, again, once we create the instructions document, we can create some exceptions because if it's you, the CCO, that did it, we don't need to see EOCCO down the whole column, right? We would only be interested in like the NEMT brokerage name or the subcontractor downstream entity name. Those are really the ones where we're looking for specific names.
Okay.
And Christina, I think we're open to feedback on that. We might be able to back into that if we have an updated list, through some of the changes that we're making to the subcontractor and delegated work reports. We might be able to identify, who's the contractor that we're talking about here. If you only have, one NEMT subcontractor, in the instances in which you have more than one, for example, multiple dental subcontractors, it might be a little less clear to be able to tell, who is the entity that actually issued the denial. So open to kind of feedback on that. and how we might be able to understand that a bit better.
Okay. That's gonna.
And I
take
guess
some thinking.
I'll go ahead, Christina.
I'm sorry. I was just gonna say that that's gonna take some thinking.
Yes, and today's not the end of the conversation. So, we really want to kind of tee up all of this. That's why we have 3 work sessions, and we can hopefully revisit some of these things in our future work sessions. Anna, do you want to go ahead?
Yeah, I guess my question, I was curious why you have the categories arranged in the way you do, but just the CCO, an NEMT contractor, or all other subcontractors, why those particular categories where only NEMT is called out and not any other, type of contractor like dental or behavioral health or physical health?
Sure. We just noticed that there's a rather large number of NEMT denials compared to the other types of subcontractors or service types that you just mentioned. And so it can be helpful to just sort of call them out separately.
Okay. Would that show up by using the service type? Because NEMT has its own service type as well.
Yes, and we're going to talk a little more about that too, because we're adding to that service type to try to get even more granular with it. But yeah, there's just a large number of NEMTs, and that's why we gave them their own category.
So you're more interested
Again,
in those specific NEMT contractors and their individual rates, and not just NEMT as a whole. Is that why? I guess I'm just curious why it's set up the way it is, because it seems oddly specific for NEMT and kind of general for everybody else.
Mm-hmm.
No, good call out.
I think I see one more hand. Jennifer, do you want to go ahead?
Sorry, I had to get my mic off. So just for clarification, so for a dental, they're a subcontractor. You'd have them as a subcontractor. You wouldn't be putting the CCO that they're affiliated with. They would be a subcontractor, and then the contractor's name would be the dental plan. Is that accurate?
Yes.
Okay.
Well, that's correct. So like Advantage Dental, Capital Dental.
But we wouldn't be putting the CCO they're associated with in that. It would be S for subcontractor.
It depends on how you're contracted, and every CCO has some granularity to how they do this, and that's why we're kind of looking for some additional information. So if you, the CCO, make the decision, but or vice versa, and the dental subcontractor is the one that issues the notice, that's what we're looking for here.
Okay,
we're looking.
That's what I needed.
Who's issuing the notice? Okay.
Perfect. Thank you.
Yeah, so just to kind of maybe take it one step up, what we're trying to understand are in those instances where we have delegated functions for the denial process and also appeal process. And I know a lot of you handle your own appeals, but there are many of you who do delegate the denial pieces to other subcontracted entities. And so that's really where we want to kind of understand who is issuing those denials and making those decisions.
And I see a question from Bill in the chat. I'm sorry, were we finished with that other? Just
Yeah.
About the intention of adding the subcontractor name to see if one subcontractor is denying more than others. That's not necessarily the intent here, though that would be interesting to see. We're really looking at something more like, did they make the decision and submit the notice out timely? And so is the CCO aware of and keeping track of, all those things? This is one more way for us to monitor the CCO's monitoring of the subcontractor, if that makes sense. That was a mouthful, I'm sorry.
Makes sense, thanks.
And I would just add that this is actually kind of something that has came up last year in compliance monitoring review as a bit of a trend across CCOs, where there were some gaps in terms of oversight of subcontractors, specifically related to the appeal and grievance system. And so this will, again, as Summer said, really position us and you, right? Because if we're seeing very specific trends in certain areas related to certain subcontractors, we can reach out and kind of share that information with you all, and you can have, you know, some very direct conversations with your subcontractors to figure out what's going on. So that's kind of where we're moving to, is to really have more of a we're building out a dashboard and really you know, kind of having more opportunities to be able to identify those trends and patterns before they become an issue, right? On all fronts, right? Not just for you all as CCOs, but also for OHA. And then I think Anna's question is a new one there in the chat. I don't think we've responded to that. Issuing.
The issue of giving you more info than the
Maybe
service type. No, not necessarily. It's just different information, because service type only tells us one thing, right? It'll tell us that it's a dental service was denied, but then we don't know who issued the denial. So sort of back to those earlier conversations we were just talking about.
Yeah.
But if you have the issuing contractor name, you would know who issued the denial.
Yes, yes. And so again,
it provides more information using the service type rather than that column P code, which is fairly limited.
This one here. Yeah.
Column O is fairly limited. We're trying to feel out and figure out what's going to work best for everybody, because we do have access, as Veronica mentioned earlier, to some of the subcontractor information, like the NEMT. Most CCOs only have one NEMT provider. So it would only be in those instances where there's additional that we might need additional info. So we're sort of playing around and trying to figure out what's going to work best. And that's why you see these two columns here. I don't know that both columns will stay, but that's what these conversations are all about. So thank you so much for the question. And yeah, let's keep talking.
Fair point. And point taken that, you know, column Q probably has more value than column P. Okay. Any other questions on this tab before we move along? We're going to transition over to the PA log tab. We'll give it a minute or so.
This is Christina. I'm sorry.
Go ahead.
I feel like I'm hitting the buzzer constantly. So I noticed in the PA log tab that it has the HRSN cover, like the HRSN information. Wouldn't some of the HRSN information want it to be listed in the NOABD tab to see? I'm sorry. No, I confused myself. It's supposed to be in the appeal log tab. Sorry. I'll wait.
Okay. Anyone else have anything before we move on to the PA log? And this is kind of where the meat of our conversation is really going to be today in this PA log tab.
This is Jill. Summer, you did say that the NOABD law will still have the PA NOABDs, right? We'll just take, we won't need to put the diagnosis procedure codes that we already put on the PA log? Okay, perfect.
Exactly. Yep, okay.
That freaked our people out.
Yeah. Oh, no, we don't want you to duplicate. That's why we created those IDs in the first place, so we could crosswalk data between the tabs. So no worries.
Yeah, so we have that tab. So yeah, so this is large, that, as Summer said, that's largely to really track the claim denial pieces here for the diagnosis and procedure codes. And then we have that PAID that we can connect to the PA log. So with that, I'm going to go over to that tab. And just flipping back to our slides, if I can find them here. So on this, I went too far. Here we go. Amanda, do you maybe quickly want to touch on the first two bullet points, and then we'll touch on the last two, and then we'll go over to look at the log momentarily?
Happy to. So in both cases, and then this will apply when we talk about referrals to HRS as well, this is data that we are trying to collect and trying to sort out, again, the best place to collect it. So HRSN covered population, right now you all are reporting about this in the Exhibit L logs. And some of that data, long term, we will get more and more of that data through MMIS. Covered population is not something you'll be submitting in your encounter data. And so we are trying to sort out the best spot to continue collecting information on HRSN covered population. And our proposal is to put that into the prior authorization log, which would allow us to understand for each request that is coming in, what is the covered population for that request, and be able to track that through to the service utilization, the denials, et cetera, from there. The second bullet is about the source of the request. And so one thing, I guess, to clarify overall, our understanding of this prior authorization log in the case of HRSN is that really we're the language we use in the HRSN space is all around HRSN requests. And so what we are understanding, and I think want to confirm with all of you as well, is that we would be treating this prior authorization log essentially as the log of HRSN requests. And so in understanding the requests, one thing that's important for our evaluation and also just the monitoring of the program overall is to understand where that request is coming from. Is it coming from a member self-referral or family member self-referral? Is it coming from an HRSN provider or partner? And so that's the purpose of that second bullet here.
Any questions on those two before we dive into the other two, which are very similar to what we just talked about in the NOABD log tab? So we won't have a ton to add here. Oh, I see a few hands. Let's see who's first. Melody, do you want to go ahead?
Yes, thank you so much. I was curious about the column C for HRSN covered population. Is the intention of that column that it would be a yes/no field if they are or are not part of the population? Or would there be some sort of identifier to determine which part of the population they fall into?
That is a great question. What we've been envisioning is actually a drop down. And so that is in the Exhibit L reporting, which I recognize you may not be involved directly in, but in the Exhibit L reporting, we are collecting information about the specific covered population. In that report, we're also collecting information on additional populations under it, since many people fall into more than one population. But we are envisioning it being a collection of not just a yes/no binary, but really which covered population specific to those lines that are relevant for HRSN. And that is it. I'm seeing Anna's kind of follow-up question. I know there are other hands up, but just to address this quickly, what should be reported when a member is in multiple populations? That is something that we are dealing with currently. I think with many of you potentially as well, with the member survey or the CCO survey that we've been collecting. I think that's something we would love to get feedback on. Got a little bit at a meeting this morning about how best to approach that, but without, adding multiple lines or multiple columns or anything like that, but being able to give you the flexibility to select more than one covered population. In our original vision, we have been just thinking about a drop down of specific populations where you would be able to select one.
Thank you.
Yeah.
And I think
go ahead,
I think I think part of the conversation that we'd like to have with all of you is to understand kind of the impact of some of these changes, recognizing that everybody has a different internal process to complete the appeal and grievance logs and the submission of those and the gathering of the data that feeds into the logs. I think we really want to hear, what all of these, what's the impact of all of these changes. So I think I just saw another hand, and I thought I had seen maybe Christina's hand up previously, but we'll go to Anna first, and then Christina, if you want to chime in with anything, feel free.
Thank you. My question, I guess, gets a little bit to the impact for us to include these HRSN additions. We process our HRSN requests through the same system that we do, medical and behavioral health prior authorizations. So we have all of those same fields available to us for reporting. But, these are obviously different ones that aren't required in other PA processes. We do have some ability to create custom fields that we can use for reporting. And so that's what this would require. And so my question was really geared toward what is the long-term, kind of requirement? Because once those are created, like they're in the system, they're there forever. You can't get rid of them because there's historical data attached to them and they're on the screen for everybody, using the system. So those are some of the considerations we were talking about internally reviewing this is how do we, do we need to balance that with this is a long-term requirement, we should just do it and put them in there? Or is this potentially short-term and we should find some other, maybe more laborious way to do it internally, but not, potentially clog up our system for years to come?
Yeah, thank you, Anna. I think that's a great question. And I think for especially the covered population in particular, it is hard to say. And I'm seeing what you're seeing your points. I mean, in the current demonstration, these are our covered populations. I think if we continue as we hope to this sort of service over time, I would imagine we would continue having certain covered populations for a number of years. That's not to say that they would be the same covered populations after this demonstration, or that there, wouldn't be some future that where these services might be offered to all populations. So I definitely see what you're saying in the question. And I guess one question back to you, since I'm not in this world, that you are in these kind of understanding all the implications of these changes, is kind of what your kind of what the perspective is on the long-term nature and what is long-term. I'm assuming you're meaning well past this demonstration period, but I want to check my assumptions.
Yeah, I think, looking past the demonstration period or, even a year from now, is this going to be something that needs to be included? And especially the requesting source, that isn't something we've reported ever for any other kind of prior authorization. And I understand it's unique, it's a different situation for the HRSN. We get, self-referrals from members. But I guess that's really my question, is reporting it in this way requires some not insignificant system changes that affect a lot of other work processes. So that's something we were just, hoping to try to balance against the need for reporting it in this particular way, in this particular report, I guess.
Yeah. Yep. That's great feedback and questions. I mean, I think not being able to predict the future, obviously, and also not being able to speak for the full program, of course, but I think from a reporting perspective, we are thinking about this as long-term in the sense of more than a year, certainly. And like through the course of the demonstration, I think what I mentioned about, we can't predict what would happen after the demonstration, what would happen in terms of what kinds of populations, all of those things are true. And all of that said, I think if there are other, part of the reason we're bringing this is you all do so many different types of reports and have a sense of the systems changes. So if there are other ways that make less of an impact to collect this type of information, we really want to hear that as well. If there's another way to, or another report where you wouldn't have to balance those same things, then that would be welcome. Go ahead.
Okay, I guess maybe the question is, are you looking to gather this information at the member level? Because this is member level data, because we also have more aggregated data, I think, on the Exhibit L report that I think we're talking about including at least the covered population, if I'm remembering correctly. I know we're currently doing like a monthly, Excel kind of spreadsheet that's a manual process for us. But also, we're currently at low volume for some of these services, and it's just climate services that are rolled out. So I'm thinking, how do we balance that, when it's low volume and limited things, it's easy to do manually, but we'll need to scale it at some point. And does it need to be member level? Is aggregate reporting, enough? That those I think are some considerations for OHA. What is it you need out of the report?
That's very helpful. Those very helpful questions. And I think in terms of some of the member level, I mean, immediately thinking about how we might look at this, at the information, at the members' experience by covered population and, race, ethnicity, language, disability. That's always something on our mind, and whether or not we get member level data or aggregate. But I really appreciate your points, and I think that's something we can go back and consider. And I want to just be clear, because this is being collected in the Exhibit L, that we're not talking about adding duplicate reporting when we bring this particular one to you all. What we're looking at is whether to transition to a more appropriate reporting vehicle, especially as aspects of the Exhibit L are going to start getting more and more duplicative with the encounter data. So just wanted to make sure that was really clear as well. And thank you, Jill, for the feedback in the chat.
Melody, do you want to go ahead?
Yeah, just one more question. For determining what would be included on this report, would it be capturing both whether or not a person met the conditions of being considered a part of the covered population, and also if they were approved for a particular provision, like if they were approved for, say, an air conditioner or something, or would it only be capturing when we actually, after we've determined that they're part of that covered population, and then we've determined if they get to have a service or not? Does that question, I might be not phrasing that question entirely appropriately.
I think I'm, let me see if I'm following. I think what you're asking is sort of the full prior authorization log. Will all of these have like will all of the data here be relevant to someone who has a covered population or does not have a covered population? Is that
so when we get a request, if say we got a request for someone who did not meet criteria for being considered part of a covered population, would we also be capturing those requests on this prior authorization log, or would it only be once we have determined they are a covered population, we are indicating that they are approved or denied for services?
That is a great question. So I think our intent or understanding of how this log would function, and from a data perspective, is that we would see members who there was a request made and it turned out that they were not eligible, that they were not part of and that may be because they're not part of a covered population. And so that's something in this column for us to consider in terms of being able to select that, they're not part of a covered population, even though they may have requested an HRSN service. So just something I'm thinking about. And then I think also Go ahead, Veronica.
Amanda, can I just quickly on that one?
Yeah.
We might want to just take that back and maybe think through it, because I think some of the discussion this morning at the HRSN work group may have indicated that there might be, certain so the review of whether someone is a covered population or not may not actually be tied to the actual clinical review of the, whether the service is appropriate for that person. So we might want to just think through that a little bit and see if there's anything there that we might need to just, kind of dig into and talk further about.
Thank you so much.
Thank you. Really appreciate it.
And I think we answered all of the questions in the chat potentially, but let's maybe jump over and the HRSN conversation we can come back to. So if anyone kind of thinks about anything else, we'll circle back to that. I would maybe let's move to the changes in columns J and K. So these are again similar additions as what we added to the NOABD log, to really kind of understand who is making some of those decisions around the services that are being requested through a prior authorization. Summer, please feel free to add anything else you would like to add there.
No, nothing else. That's it in a nutshell. It's just exactly like what we have on the NOABD log. Just again, looking for more specifics as far as who's making the decisions.
Any questions and or comments on that piece? And again, I think the point you raised earlier, Anna, about column J maybe not being as helpful, definitely something that we can take back and consider and kind of think through that. I don't want to cut the HRSN conversation short because that's kind of one of the primary things that we are here to discuss today. So I want to see if there are any other thoughts about the two columns, column C and E, and more conversation maybe that we need to have around those. Go ahead, Melody.
Yeah, sorry, just one more question. On column F, would that likewise also be predetermined values, or is the intent of that would be free text, similar to how we might put in a provider name or something now for like a grievance?
You said column K, is that correct, Melody, or did I hear?
For column F, the HRSN request source. Yeah.
Okay, so E. Okay. Or
yeah,
or
sorry.
do you actually mean F? Sorry.
Nope, I added notes to mine, so I am off on one column.
So great question. And what we were envisioning was more what this is draft, like Veronica said before, but what is written there of just a roll up, a drop down with it, whether it's a self or member referral versus whether it's coming from an HRSN provider connector, and then something to indicate too whether it's something that is coming from CCO direct outreach is probably another source we would want to capture, and anything else you all could think of that would be more relevant based on how the programs are operating, but not at the level. I think part of your question was like at the level of the authorizing contractor name. So we weren't envisioning a specific name going in there, but more a category of where that is coming from.
Okay, great. Thank you so much.
Absolutely.
Okay. Well, I'm going to jump us back to slides, and then we're going to kind of continue to some related conversations. We're now going to look at the code table changes, and there are several changes to the code table document that was sent out that reflect some of the additions to some of the kind of support some of the HRSN specific changes. First, you'll notice in the document that we have added rows for in the service type tab and in the subcategory tab. We've added some not rows, sorry, columns where we have service type examples and explanations. And so the goal really there is to kind of provide some very specific examples that we thought might be helpful descriptors to assist CCOs in identifying which service type to select. And some of this is based on what we were seeing in the data. So I'm gonna maybe turn it over to Summer to talk a little bit about anything else that you want to add to that, Summer.
Just that this is still a work in progress, and we are open to hearing, kind of the ways that you're currently utilizing these service types so that we can better populate those service types, examples, and explanations. We've put in a few examples here so you can get an idea of where we want to go with this. But the idea is that any staff member can look at this code table and know exactly which service type they should be selecting when doing the reporting. So again, it's a work in progress, and we are definitely open to hearing some feedback from you all and any ideas that you might have for this column. Please send it our way.
Thank you. And some of this granularity is going to be really helpful to kind of start to draw out some of the places where we maybe aren't getting as granular with the information. As we were working on kind of the MACPAR reporting, we noticed that there were several service types that just didn't have any information being reported for them. And this is across, an entire year. And so, for example, I think behavioral health inpatient was one of those where, so that information must be getting, it's probably getting maybe combined with another category or included in the other category, which is being used extensively. And so we want to make sure that we're just getting as granular as possible about individual service types. Anna, your hand just went up. Do you want to go ahead before we move on to the next set of bullets?
Oh, I guess I wasn't sure. Are you taking questions about the service type changes now, or are we doing that?
Let us maybe walk through all of the service type code changes, and then we'll come to you right after that. Okay. Amanda, do you want to kick off with your changes?
Sure, happy to. I think the main changes here that you see on the slides are the housing code and the addition of the nutrition code. So there's already a code for us to be able to determine, is this a climate service, or is it, I believe, outreach and engagement as well. And what we're looking at is needing to add for the launch of housing in November, and then 2025 for nutrition, those additional codes. So as those services come online, the one thing I will note is that we are really want to make sure that we align the addition of the housing code with the launch of that program, and also seeing that coming up quickly, of course. And so I think just want to call out there that I think that would be more potentially along the lines of that Q4 of 2024 collection, and that, understand any kind of systems impacts with that in mind. I think that's all for me, unless I'm missing something, Veronica.
I believe that was right. And let me actually bring up the code table for us to look at together. Okay. So here are the two HRSN related changes. Let me make this bigger for folks to see. Okay. And then let's maybe jump over to the other changes. And Summer, if I can rely on you to go through the service type changes, and then maybe we'll circle back to conversation here on these proposed changes.
You bet. So just going by what's on your screen right now, when we look at service types 1, 4, and 6, these ones we're simply just adding a little bit of clarifying verbiage to help further understand what it is we're looking for in that service type. I'll pick on service type 4 and 4.1 as an example. We want to keep service type 4, the hospital, but now we need to differentiate between general inpatient on the physical health side and then behavioral health inpatient. And again, that's tied to CMS reporting that we must do now. It's sort of all been lumped together in the past. So we definitely want to call these out a little separately, but keep the service code intact for historical purposes, and just we're inserting a new service code there, 4.1, to capture the behavioral health piece. Okay, let's scroll down a bit, if we can, to 18 and beyond. Yeah, so 18 we found to be, we thought it would be better described with lab, and then giving, examples of what that would entail, like blood work, what have you, so that it didn't get confused with imaging, because we've seen some mixed results as far as how CCOs were interpreting those. So we want to have a separate lab and a separate imaging code. Moving down to 20.1, we talked about this a little, I referenced this a little earlier. So when it comes to NEMT, we want to now separate NEMT service type from NEMT reimbursement service type, so that we can get a little more granular when we're looking at those denials. Moving down to 28 through 40. Yeah, 28 through 39, really. These are simply additions that have previously been missing, and will allow all of us to better understand, what's happening, across the spectrum, grievances, denials, appeals, etc. We just needed some more granularity here. A lot of services were missing, and it was tough to figure out where they should fall into in the previous bucket. So that's what that's about. And then Code 40 is another example of CMS reporting piece that we now need, again, that was previously missing. Okay, I think I've wrapped that up in. Yeah.
And this is our stab, like our initial draft, right, of service categories that we believe are missing. I think if there are any others that you all are interested in adding or tracking long term, then we're definitely open to that conversation. Amanda, we'll go to you, and then we'll go to Anna right after that.
And actually, I just wanted to call attention. I don't know why I raised my hand in that way, but to Anna's comment in the chat. Anna, that's a really good point, that I think we were, of course, trying to minimize the coding additions and thinking about prior authorization and NOABDs. And Veronica, maybe we need to revisit that for grievances and appeals for our outreach and engagement. So thank you, Anna. Super helpful.
So to have a separate HRSN outreach and engagement specific category. Okay. All right.
Yeah, I was thinking about the meeting earlier today with, potential for claim denials, which would generate an NOABD, and the potential for member complaints, of course, if they have a complaint about a service they've received in some way.
Mm-hmm. Yeah, thanks for calling that out. Okay.
If I could jump into some of the questions my team had around the
Feel
service
free.
types. Some of our questions kind of in general are around when these service types overlap, because there's a lot of them that are overlapping service types. There's outpatient and many, many other things that are offered as outpatient services. So what service type should we use? family planning and pharmacy, those kinds of things are, which service type should that be? And also just maybe as a general note for how we use these service types in reporting. For our member complaints, generally those service types are assigned by a human person who's taking that complaint, over the phone or, working with the member to categorize the complaint. They choose complaint categories and they choose the service type. For our prior authorizations and NOABD service types, those are assigned based on a, code mapping that we do on the back end. So when a prior authorization comes in, the reviewer is not choosing a service type as part of their review of that. We have that mapped in order to report out based on provider specialty or place of service or, the service that's being requested, CPT codes or something like that. And the same for NOABDs. And so, we were wondering, do you have a preferred way, or have you thought about a preferred way to do some of that mapping, so that we're doing, more of an apples to apples comparison across PAs and NOABDs, including claims denials and things, so that you're getting the same information from us across all the tabs of our report and potentially between all the other CCOs as well.
I'll just jump in. Great point. I don't know that we've really gotten that far, but I'm really happy that you brought that information to light. Veronica, go ahead.
Yeah, I was gonna say something similar, and I think this is I welcome any other thoughts, Anna, that you might have on that particular piece, because I think the next phase after we kind of work through some of this with you all and figure out where to land will be to look at, as I said, the instructions, but also improving the quality of the reporting overall, and that's where our kind of our data analysts are going to come in to try to help do that. And I think the question that you're raising is really going to be, critical, obviously, to that thinking and some of that process. So welcome any other kind of thoughts or feedback that you might have, like very specific feedback on that would be really helpful as we start to think about how to ensure, kind of consistency across the tabs and between CCOs. Thanks for raising that. Let's see, anyone else have any other comments or thoughts on the service types before we move on? Yeah, go ahead, Summer. Yeah.
There's one thing I forgot to mention as we were going through, and that's service type 17, the other service type that has been used quite frequently. We want to, again, and that's part of the reason that we're attempting to add additional service types so that we don't have to use that code so frequently, because it doesn't give us any really good data. So we've incorporated column D there, the orange column, for this line item only. If there really is no other service type that fits the bill, we would like you to, fill in the blank and let us know what we're missing. And these will be reviewed so that we can continuously improve the service types. Okay, that's it.
Thank you, Summer. And then Anna just dropped something in the chat related to transition of care. We do have the care coordination, case management. Oh, and we do have, oh, okay. So maybe Anna, why don't you tell me what you are, what you would like to pose? Are you wondering about transition of care as like its own separate service type? Because we do, obviously, we have 37, right? We have care coordination, case management. It could fit there. But maybe explain a little bit more of what you're thinking or your question.
Well, I guess we were struggling to see transition of care as a specific service that would be happening for a member. I could think of situations where it might be a service type in a complaint. If there's a transition of care situation and the member is having issues and has a complaint about something. But I think more often it would end up in a pharmacy complaint or a outpatient, other specialty service complaint if they're not able to, get their appointment scheduled or something along those lines, or potentially um, an appeal if there was a denial that should have been approved during a transition of care time period. I guess I think of it as a time period and a process and not a service that's provided.
That is a good point. We will definitely consider that as we kind of look at changes to the log here, or this tab specifically.
Okay, yeah, and if you have examples of how that would be used, that would be helpful for us, because that was just something we couldn't think of any examples that we knew of.
Yeah, and I don't know, Summer, if there's any other background you want to offer here, but I think it's a really fair point. I agree that we typically do think about it as a process, and not necessarily as its own service. It's a service itself.
Mm-hmm. And if I could just comment on the other category, number 17 or whatever number it is.
Sure.
I think that's one I know we've been guilty of using a lot, and that again is due to the way we map those, different services for reporting, especially on our claims NOABDs right now, because there's a lot, we have some things mapped based on, maybe code sets that are used for specific services where there's a code set that ties nicely to a service type, or a provider specialty that ties nicely to a service type. But after we do kind of our best to track those, and then we're left with a lot of things that end up not being mapped easily. And those end up in the other bucket just because of the sheer volume of, having a person review all of those to try to figure out what service type they might fall into. Just is not really feasible. We don't have the capacity staff-wise to do that. So we're looking for more ways to automate that process and have a mapping system that makes sense to bucket those different claims and PAs into service types that are meaningful.
It's very helpful. I think I would welcome all of you maybe to let us know, what's ending up in that other category. I think so. I had the pleasure of entering our MacPAR data into CMS system, and I definitely saw that this other category is highly utilized. So I would really want to understand maybe what's ending up in that category currently, and then that might be helpful for us as we think about either identifying other service types or mapping things so that we have being more clear maybe about other service types that aren't getting captured. And I think that instance of the claim denials and having multiple service types included there, that's definitely something worthwhile thinking about, and welcome any other feedback that you all have on that particular case or kind of issue that you're seeing. I don't know, Simmer, if there's anything you want to call out there specifically. Okay.
Nope.
All right. Any other, let's see if there are any other. It's 3:22 actually, and I'm going to move us along because I just noticed that we are where we are in time. So let me bring up slides again. All right, we're going to move over to the subcategory codes tab. And this is just an overview. Why don't I bring up the log, because sometimes I think it's a little easier to follow all the things. But here are the kind of general bullet points. And then Amanda, if you want to jump in with your changes. Actually,
Yeah.
I think I might have to go back to slides. Sorry.
Well, no, that's fine. I think I can see it on either. It looks like it's
Okay.
in red noted in there. So, and this is not so much a change, really more of a flag, I think, of guidance that we would want to present. What we're trying to do here is to make sure that it's clear that when it's an HRSN service, which coding to pick based on what the situation is. Is it that they weren't part of a covered population? Then we would see that in category 1 or code 1, and versus not meeting clinical risk factor criteria in 14. The one thing I think we did want to just ask about in terms of other information to capture is social risk. And so something that is not as important in some ways with climate and housing, because it's a little more of a straightforward determination of social risk. But we know as nutrition launches, there will be more of a screening to qualify in terms of social risk that's required. And so that is something that without an additional code, we're not sure we could distinguish that, and wanted to throw that out as a little bit more of a question to you all of whether that's something you anticipate tracking and would be reportable in this kind of format. And we don't have a lot of time, so that might be something to sit with and return to, but I'll just call it out for today.
Okay. And then Summer, do you want to quickly maybe talk about 15 here, the subcategory?
Yeah, this one's just fairly straightforward as you see it on the screen. I don't have any other background info for you, but wanting to add the lack of referral when a referral is required for the claims NOABD specifically. Apparently that's a category that's been missing, and folks are wanting to add that one. So that's all I got.
Thank you, Summer. And let me come back to the slides. Sorry for all the bouncing around. We'll jump over. So we've covered quite a few of these questions throughout our conversation here today. But Amanda, is there anything else you want to maybe call out?
Yeah, I think what I want to do here, since it wasn't explicitly also in the proposed changes for you all to vet with teams, it sounds like many of you are doing, is this first one here. So we are trying to sort out how can we track the HRS when a member has been referred to HRS services if they've been declined for HRSN services. And in most cases, probably because they weren't part of a qualifying covered population. And so we do have a proposal of maybe it is most straightforward to track that in this report, and that we would that would require adding another column to have that kind of HRS referral yes, no for those that have a denial. But that's something that we're trying to sort out if that's a good way to track it, if there's a better way to track it based on how you all are tracking that in your own systems. I do see Anna's comment that member level HRSN data will be reported on the HRSN services template. The encounter data. So yes, we will have, I'm not sure I'm completely following Anna, but we will have the member level data for HRSN. What we're trying to get at here is if someone does not qualify and is being denied HRSN services, we know that most of you are then referring over to HRS in many cases. And what we're trying to do is track that so we can tell the fuller picture of members receiving services via this new program or through HRS. It's kind of like a holistic sense of your
my
efforts.
comment was back to
Oh,
where
okay.
where else
Yeah.
might we be reporting the HRSN covered population
I see.
and information that we had talked about earlier in the PA log. I was messaging with some other coworkers to find out what other reporting avenues they're familiar with. So
Got it. Okay. Thank you, Anna, for clarifying. Yes. So, and I think we are definitely open to if there are other ideas. I know there's some work that we will be doing, Veronica and I and our teams in the coming months to look at care coordination reporting and how HRSN data points might fit into those reports. We know we have the Exhibit L, though, as I mentioned, that's something that won't be in the same form over time as encounter data really comes online through MMIS. So just really open here in terms of your feedback on this particular proposal and also your feedback on how you could best report on HRS services provided to those members who are declined for HRSN. I know we're right about at time, but appreciate you allowing me to put that out there.
And we are, I think, with that, I mean, and just kind of melding all the conversations together, we heard during the DSN feedback session, right, when we were talking about the HRSN changes, that HRS services are tracked very differently. In a previous conversation where and reason for that being that they're optional services, right? In a previous conversation that we had at Contracts and Compliance, we heard from many of you that many of you likely will be referring, an HRSN denied service over to HRS, and that you were making attempts to align your criteria between the two. However, I don't know that is the case for everybody, and so I think it's really we really want to hear from you all on this particular piece, and also maybe to understand kind of the timing, because it may be that some of you might wait to consider if something is covered by HRS after a member appeals, if they are denied. So the timing, I think, comes into play here too, right? Because we don't know, are you automatically considering them? Is it moving right over to the HRS team and process for consideration, or are you holding until kind of that full appeal process plays out? So all things that I think we'd love for you to consider, and maybe we can circle back on these pieces next time when we meet, and it gives you an opportunity to kind of talk with your teams and chat more about those. And meanwhile, I saw Jill, and I know we're slightly over time here, but I want to, Jill, can you maybe just expand a little bit more on massage? I want to maybe see massage as a service type. If you also want to include or have that kind of maybe be rolled up under the PT category, or have it be something, actually, now that I think about it, I'm not sure if we have PT on the list, so we might need to add that.
I think PT and OT
Okay.
are together, and I think having massage separate makes more sense because it's not always done in the same place. I mean, it should be if it's medical, but it isn't always. And people ask for it just because they want, and so they ask for it from they want to go to a massage place and have a massage.
Okay, that's helpful. Thank you. All right. So with that, we are going to wrap up here today. We have, as I mentioned, our next session on July 30th. And let me just quickly check the time because I don't remember it off the top of my head. July 30th. Okay, so our next session together will be, as I mentioned, on July 30th and the 31st. The session on the 30th is from 3 to 4:30, and then the session on the 31st is from 11:30 to 1. So we'll be revisiting some of the kind of outstanding questions, largely related to HRSN, And then we'll also kind of be tackling the grievance log changes next time we meet as well. And meanwhile, if you would like to submit any feedback, you can submit that to the HSD Quality Assurance mailbox. We will see if we can drop that link in the chat here really quickly, and then that will help us kind of, work on making changes. Thank you so much, Summer. That will help us work on making changes to the reports between now and when we talk next time, and we can share those with you all during the next conversation. So with that, thank you all so much. We really appreciate your time and feedback, and look forward to your continued feedback and engagement on this topic. Thank you.
Thank you.
Thank you.
Thank you.